This is Dr. Deukmedjian, the CEO and founder of the Deuk Spine Institute, here with you on November 30th, 2021. That's it? You're right.
No, this is an 8.
Oh, an 8?
You can assault it.
You know what? It's not bad.
Really?
I don't know why, but it doesn't feel like an 8. Not yet, right? You know, let's just go with it.
It feels good?
I mean, I don't have tingling yet.
Okay. What is it?
So, I'm sorry, we're getting a little distracted here, but we're in the operating room at Surgery Center Viera and Deuk Spine Institute, getting ready to perform a surgery of the spine, specifically a cervical spine, which is in the neck. And our patient has 3 herniated discs. One is at C3-4, another at 4-5, and another at 5-6. Now, we could have done a fusion like we did with the last patient. We did this morning, but this patient didn't want fusion. She wanted endoscopic laser surgery. That's what we're doing today. And if you've never watched one of these before, this will be the first time you've probably ever seen it or heard of it. It's all done with a small incision, 4 millimeters, and usually we can fix 3 discs with 1 incision. All right, let me just take a moment and then we'll get started, but I have to palpate the spine. I could feel it there. Can you help me with her head? So her tendency when I push is going to be to flex. If you can keep her extended by holding her skull, like a kind of like inline traction.
Your neck is actually extended. The position that you position there.
Oh no, I'm sure it is, but as soon as I push on her neck, she starts to flex. So if you can give me a little bit more extension, you can even push the occiput towards the feet if you want. That's good. There's the spine right there. I can feel it. And that's the key to the surgery. Shot. We need to feel the spine. 2, 3, 4, 5, 6. So we're going to 4, 5 first. Agree? Luis? Let's see what we got here. Shot. Shot. Yeah, give me a AP. Shot. Hold on. Come on. It's a shot and an AP. Quick, quick, quick. Nobody move. Shot, quick. AP. I need to see if I'm in the midline. I am. Lateral. Let me know when you're ready. Shot. Shot. Okay, coming out. Coker. You can relax, doctor. You can relax. Now, give me an AP.
Yeah.
Okay, 2, 3, 4, 5. Luis. Oh my God, it's perfect. Look at that. Right in the middle. I love it. I love it when the plan comes together. Oh, you forgot the esophageal tube. When am I going to get my staff to do what they're supposed to do? Okay, for these, I like to have an esophageal temperature probe. It's okay now. It just helps mobilize the esophagus. But now, are you going to remind the anesthesiologist from now on? Are you going to remind the anesthesiologist from now on?
Yeah.
Good.
You're going to use that correct?
You? All right. So the reason I'm talking to my staff about this is there's 2 things that I need to make sure, actually 3 things I need to make sure I don't puncture. Anything in the carotid sheath, which is the carotid artery, jugular vein, the esophagus, and the trachea. And I'm actually going between them, just like we did last surgery. So if you rewind, if you look on YouTube and you go back 1 surgery, you'll see what we did was something called an anterior cervical discectomy and fusion. By the way, that patient's gone home. Yes.
It's not too late to put the tube if you
No,
want.
no, 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 no.
I am not going to.
Yeah, if you could put it, do it.
I can.
Yeah. Okay, so we just did an ACDF and the incision for that thing was this long. Now this patient will have a 4 mm incision instead. That 4 mm incision, we're going to do everything endoscopic. So instead of doing an open surgery, we're doing it endoscopically. That last patient that you all just watched surgery on, if you were here last surgery, this morning, that patient's already gone home. He's up, walking around. He's doing fantastic. His neck pain is gone. Headaches are gone. His pain going from his neck into his shoulders is gone. The pain, I asked him, it used to go down to his elbow, gone. So the only thing he has is a sore throat from having the tube down. And he also has carpal tunnel syndrome, so he's got some pain in his palm, but that has nothing to do with his neck. But he's literally gone home already. So for those of you who have never seen a 3-level ACDF outpatient, that patient's already gone an hour and a half after he was done with surgery. Okay, we are ready to keep going while my anesthesiologist puts in an esophageal temperature probe. I'm going to do my discogram at C4-5. Shot. Could feel it. Shot. And it's leaking out the front. It is also leaking out the back, but I like it to leak a little more out the back. There's a lot of scar tissue back there. That's what's blocking it. Okay, that's good. Okay, so we just did our discogram. We injected about a cc of this material. It's a liquid, and it's really a combination of sterile saline, Omnipaque, and something called indigo carmine. And it's a 10% indigo carmine. Is it a 30% Omnipaque? 30%? Is it 3 cc's per 10 of Omnipaque? Yeah. All right. So 30% Omnipaque, 10% indigo carmine, and a little preservative-free Marcaine. Not in cervical. No. Just lumbar. From now on. Yeah, I know. Let's change it. Okay, at this point, we are in the middle disc, and we're going to have to fix this one, plus the one below and the one above. Everybody in agreement? We're doing 3, 4, 4, 5, 5, 6. Doctor, let me know when you're done. And you're good? See? Oh, there it is. Yeah, there it is. We see it. Thank you. Okay, so I'm going to proceed as soon as you're finished. Let me know when you're finished.
Okay. Finished.
You're finished. Perfect. So at this point, we've got our guide wire in. Shot. All right. I need to get my guide wire in just a little bit further. Shot. Well, I guess that's as far as the guide wire wants to go. That's fine. I'm going to take my needle out, leaving the guide wire in. Shot. That's it?
Yes, sir.
Okay, good. Now, as you can see, so far I have a percutaneous procedure going on here with the needle and the guide wire. We're about to open this up and do an incision. Once you make an incision, it's no longer percutaneous. Percutaneous means done with a needle through the skin. Once we make an incision, it's a surgical procedure. This is a surgical procedure. I'm trying to, is there epinephrine in here?
Yes, sir. Yes, sir.
I mean, I did a little needle stick and I got more bleeding than I do the whole surgery with just the needle. All right, so I'm going to put a little pressure here. Just give it a second. Shot. Perfect. All right, so we're going to give the medicine a minute to work. This medicine that we're putting in now is a subcutaneous local anesthetic called Marcaine and a little epinephrine. I'm going to make a 4 mm incision. 4 mm is very, very tiny, but that's what we do the whole surgery through, is a 4 mm incision. Right against the guide wire. Okay? Next, I'm going to bring this dilator down over the guide wire. And I know I've got a safe path through the neck, because that's what I created initially in the very beginning, was a safe path with the needle. Remember in the beginning I put my fingers on the neck, I displaced the esophagus and trachea immediately and the carotid sheath and its contents laterally. Okay, and that created a safe path to do this endoscopic surgery. That's the key to the whole surgery right there. Okay, at this point I have the tip of the dilator on the front of the spine. Remember, if you watched the last surgery, at the front of the spine we had the anterior longitudinal ligament between the longus coli muscles. Now we need an AP. So we're gonna, on the lateral view, we're in the front of the spine sitting on the ALL. On the AP view, we want to make sure we're somewhere near the middle of the spine. Shot. And there it is. We are. Beautiful. Right in the middle of the spine. Now if you get too far left or too far right, you're going to go through the longus coli muscle. You don't want to do that. It's not going to really be a huge problem, but it's better to avoid doing that. Oh, by the way, show them on that x-ray picture. Oh no, the AP. Can you pull back the AP? You just had the AP. Okay, Diego, I want you to show the AP view. Bring it up.
Okay.
Oh my God, Jordan. You're kidding me. Why can't you go back one picture? This machine should be saving images.
I can go back to the images if it's saved on a different one. I don't think they can see that.
You can't see it. All right. Go back to an AP. And do not change your view until I tell you to, okay? You just reshot the picture. I didn't want you to reshoot the picture. Now, show them now go back to a lateral and show them, do not take the lateral picture. And show them the tear and the leakage of the dye into the foramen on that left side. It's her left arm that bothers her. I'm going to show you the annular tear. And it's a big tear right there. You see that black thing? He's pointing the arrow to. You got that, Diego? Do you see it? Diego?
Yes, we see it.
All right. Good. Now, let's go back to a lateral view. That is the tear in the back of the disc where the dye is leaking out. That is where the inflammatory juices are leaking out onto the nerve root. Lateral. You're pulsing, right?
Yes, sir.
All right, so we're entering the disc. I'm twisting and entering. Yep. And once I get this started, I'm going to remove this guide wire. And I'm going to advance the dilator with the mallet. Shot. Mallet is going to give me more control. Remember, all this is being done through a tiny 4mm incision. Shot. All right, time to bring the mallet in. The mallet is just that, it's a hammer. This is not Thor's hammer, this is Dr. Deuk's hammer. You like that? I like it. Okay. Shot. I want to get to the back of the disc, right where the annular tear is, at the base of the herniation. And that is where we are. I want to go a little further, another millimeter. All right, good. So now, over this dilator, I'm going to bring a tube. If you've never seen this surgery, it's quite incredible. The whole surgery is done through this tube. It looks like a coffee straw, but it's actually a stainless steel surgical instrument. It's called the tubular retractor. It's going to come down over the dilator, and I'm going to advance it through the neck. And you all remember last surgery I did earlier today when I moved the esophagus and tracheas one way and I moved the carotid sheath the other, and I created a space that was very big and open, and you can see the spine. I'm going through that same space, but instead of opening everything up, I'm doing it endoscopically. Shot. All right, so the tube is on the front of the spine. I'm going to advance the tube through the disc to the back of the disc. Doctor, can you give some inline traction? Just give me a little straight pull, nice and gentle. Little inline traction, perfect. Shot. And there goes the tube through the disc, shot. Shot. Almost there, shot. A little bit further, shot. Shot. That's it. All right, thank you, doctor. You can come out. Okay, so you can see the tube is at the back of the disc. I'm now removing the dilator, which is in the middle. Shot. And now you can see the tube that I'm doing the entire surgery through. It's literally docked right at the back of the disc where the herniation is. The nice thing about cervical is I can do both sides of the disc, the whole disc in the back, with just one incision on one side. All right. Hey, everything okay, Jordan? All right. Now you don't want to contaminate that, so do not back up into it, okay? Okay, come on over here. Good. Thank you, Luis. Okay, we're ready to get started on our first disc. Any questions from the audience? So why don't you go ahead and show our audience why we do the Deuk laser disc repair surgery on patients with herniated discs. Why do they get pain? Why do herniated discs cause pain? Can you run that animation? Cervical disc
can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.
Back.
Okay, we're about to go in endoscopically and fix this disc. So right now, if you're looking at the endoscopic view, and what you're seeing is I'm trying to adjust the focus, make it a little bit better. It's a little bit blurry. This is a fiber optic scope, so it's never going to have as clean of an image as a rod lens scope. But what we're seeing here is we're in the back of the herniation, and the laser is at 12 o'clock. And I'm about to get started using the laser. The blue stuff is degenerative disc. Basically, it's the herniation. And the white stuff is annulus, scar tissue, could be bone. I'll tell you what it is as I encounter it. I need this over here. All right. So there's the herniation right there. We're literally right on it. That's the beauty of this endoscopic surgery, is you get right on the herniation. Now remember the last surgery we did, we literally had to dig through the patient's neck with an ACDF just to get to the disc. And then once we got to the disc, what do we have to do? We had to take the whole disc out to get to the part in the back here. Now we're just leaving everything else there, and we're just going straight for the herniation itself. That's the beauty of this procedure, is there's no need to take open the whole neck up, and there's no need to take the whole disc out because we can just fix the part in the back where the problem is. So it's kind of nice that everyone gets to see these two surgeries back to back. This one being the less invasive, more advanced surgery. There's a piece of herniation right there. Stand by. So what I'm going to do is take the scope out, reach in with a little grabber to the bottom of this tube where that piece of herniation is. I'm going to grab it out and give it to my assistant, Flynn, and go back in with the scope for round 2. Okay, going back down the tube. Once again, we're in the herniation. And this is the herniation here. This is the annular tear. And I'm just using the laser to release the herniated fragments. Right there's another piece. And the laser is quite wonderful at helping me remove these pieces of herniation because a lot of times they're stuck. They're stuck down to the annulus. And that's why we do a debridement. We do a debridement because you can't get the pieces of herniation out unless you debride the annulus itself, the annular tear, because they're stuck to the annular tear. It's kind of like fish getting stuck in a net, you know? Not in the net itself, but in the walls of the net, where you have to free them up. But we do that with a laser here. Any questions?
We have one question from Facebook.
Okay.
They're just wondering, was fusion an option for this patient?
Was fusion an option for this patient?
Yes.
The answer is yes. Yes. Anytime you have a problematic disc that's causing pain, fusion is an option. So this type of problems that the Deuk laser disc repair fixes are the same problems that a anterior cervical discectomy and fusion will fix, an ACDF. Except an ACDF can also fix deformity. Deformity is basically where the spine is kyphosing, like kinking forward, or twisting. And a lot of times fusions can fix those kind of problems, but many times they don't need to be fixed. So why have a fusion when you don't need it? The truth is, we should be saving fusions for patients that really need fusions, which is about maybe 5% of the time. Come on, guys. You guys got to think about the interplay of these things. Does that make sense?
Yes.
Anytime you have a herniated disc and pain coming from the herniated disc, a fusion will, if it's done properly, it will get rid of that pain. Okay? The problem is most surgeons that do fusions don't do the right surgery. And what I mean by that is they will do a surgery on one disc, but the patient needs 3 discs that need to be operated on. So they'll do one at a time. The patient will get some relief, and then they end up having to come back and getting a second surgery or a third surgery. And, you know, why put somebody through 3 separate surgeries when you could fix it with one surgery? That's really the question. Most spine surgeons don't know how to fix these problems with one surgery because they're not comfortable doing more than one disc at a time, or they don't recognize that the other discs are also causing problems, and they just focus on one disc and not all three. If you have 3 rattlesnakes in your house, are you going to just take one out at a time, or are you going to and leave the other ones for a year or two, or are you going to get rid of all 3? Not all herniated discs cause problems. Not all the herniated discs are painful. Most herniated discs are not painful, but when they are painful in a patient, you don't want to go in there and just fix one if 2 or 3 of them are causing pain. You need to fix all 3. Otherwise, the patient's still going to have pain when you're done with their surgery, and that's what happens all the time. I see it all the time, not my patients, but other surgeons fixing only one disc at a time. The more experienced spine surgeons that have the better results, they always fix. They're comfortable. They're not afraid of doing more than one disc at a time, and they have the best patient outcomes. So if you haven't watched our Spine Scams Exposed segment, I recommend you check it out on YouTube. And we actually saw a patient in clinic yesterday that is somebody who got scammed. This is a poor patient with schizophrenia who was treating elsewhere at another pain center. And unfortunately, there's a tendency of pain management doctors these days to just want to go for procedures that pay them the most money. So what they do is they'll start patients on some shots. Patients won't get better. They won't get any permanent relief. And then they'll, instead of referring the patient to a surgeon, the pain management doctors start putting in spinal cord stimulators and pain pumps. Now, spinal cord stimulators and pain pumps pay very well. That's why they do it. They don't do it for the patient. They do it for themselves. But those spinal cord stimulators and pain pumps, they don't work well at all. And they frequently have problems. And they stop working very soon after they're put in. They're very expensive. They cost the insurance company anywhere between $30,000 to $100,000. And these pain management docs are just putting them in left and right to make money, without really thinking about or caring about whether the patients are going to get better. I see it all the time. It's not done at Deuk Spine Institute. It's unethical, so we don't do that because it's not in the patient's best interest. But there's also this kind of reimbursement for these pumps and stimulators. They cost about $20,000 to buy, and then companies get paid around $35,000 to $100,000. And what's happening is it's a great way to make money, so all these pain management doctors are doing it. And it's really a surgical procedure, should be done by a surgeon. But they're jumping on because they can get away with doing it because it's a minimally invasive procedure. And what's happening is people are getting these stimulators and pain pumps put in, and they're not working. So they're in horrible pain. Now they've had these surgeries they didn't need and shouldn't have had in the first place. And it's kind of like when there's blood in the water, the sharks will come. Who do you think the sharks are in this situation? They're venture capitalists. And the venture capitalists have taken great interest in pain management clinics. If you're a pain management clinic these days, they're all getting bought up by venture capital companies, or they're getting bought up and as part of large chains. And then these chains go on and sell them as bulk investments to venture capitalists. Why does that matter? Because what's happening when they get bought is these doctors are being told, hey, if you were putting in 100 spinal cord stimulators before we bought you, now we want you to put in 300 in your patients. Because there's so many people with chronic back and neck pain that they all go to the pain management doctors. And these doctors have basically betrayed that patient by putting in unnecessary spinal cord stimulators and pain pumps when the patient has a simple problem that could easily be fixed with a simple, inexpensive treatment that's safe. But instead, the pain management doctors don't make any money on that. So they're doing these pumps and these stimulators that make them a lot of money. And it's totally unethical. It is bad medicine, and people are falling victim to it, and people don't know any better, which is why I'm mentioning it. Because that's what our broadcast is about. It's about teaching people the truth. So, to give you an idea, some of these pain management docs are putting in hundreds of pumps and stimulators a year. One doctor may put in 500, 1,000. Okay? And just to give you an idea, we do pain management here, but we don't promote stimulators and we don't promote pain pumps because they're dangerous and they don't work. They don't work very much. They're really reserved for very few cases, selective cases. Okay? And we do about 5 a year. And we have one of the busiest pain management practices in the country. That just goes to show you how much overutilization is the word the insurance companies like to use, and I'll borrow it from the insurance companies, but how much overutilization there is of these procedures for the basically the driving force is profit. Now, I don't believe patients should be taken advantage of that way, but I'm making you all aware of it. Do with it what you will. There's a lot of people who don't believe me. That's fine. But if you're listening out there and you're suspicious about it, be careful. Don't fall into that trap. I think about the doctors that are promoting spinal cord stimulators and pain pumps. I think about them as no different than those people that contact you and say, you know, I am in Nigeria and you have won $1 million. All you need to do is give me your bank account number and I'll send you the money. Right? And unfortunately there are people that believe those people. But they're scammers. And these doctors are no different. They're no different. So just be wary. These procedures we do, they actually fix people. Their pain is gone. And if they have some residual pain, when I'm done with them, it's coming from something else other than the disc. And I have to find that source and fix it. But we're all about fixing the pain, not covering it up with pumps and stimulators that pay very well but are not good for patients long term. Okay? I am in the foramen on the left side. That's what we're seeing down there. I've gotten rid of all the herniation. And this is a degenerated disc, by the way, in case you're wondering. It is a degenerated disc. We're done. Actually, let me put the scope back down real quick. And just let me look through the scope real quick. Sorry, I want to... Let's just look and see. Scope off. Yeah, I'm not going to do any of that. Huh? Yeah. hold that. Actually, I'm just going to hold on this one. Let's just see where we are. Get a shot, AP, while you're there. And lateral. All right, why don't you show our audience what we're doing here, Diego? Diego, can you hear me?
Yes, I can hear you.
Let me have that medicine on a skinnier needle. This needle. Can you run the video of the Deuk laser disc repair cervical?
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Shot. So we're out of the disc and we're off to my side. We want to get back towards the midline. Shot. Better lateral. We need to make our way down to the next disc. That's it right there. All right. Shot. Oh, don't move that head. Just keep her slightly extended. Yeah. Shot. Shot. That's perfect. Give me an AP. Nobody move. Almost done. And shot. Okay, it's a little off to that side. I need to bring it back to me. Shot. Mallet. Go lateral. Lateral. Shot. Good. Give me a shot. Coker AP. Almost done, doctor. So we've moved from 2, 3, 4. I'm in 5, 6. Let me have a ray. Come on. Is that it?
Yes, sir.
Lateral. Shot. Shot. Uh-huh. Shot. It's just very degenerated. Looks good. 2, 3, 4, 5, 6. You can come off.
Yeah.
Let me, no? Okay. All right, I was just gonna do it without the dye.
Okay.
No discogram.
Oh, no, this one? Okay.
I know. Because it's, I need the tube. Once again, if you joined us late, the whole surgery is done through a tiny tube, 4 millimeters. So it's minimally invasive. We've already done the 4-5 disc. Now we're at the 5-6. 2, 3, 4, 5, 6. Everybody agree 5-6 is the next disc. And then we're going to work our way up to the top. And then we'll be done. What a contrast, huh? For those of you who watched the last surgery with the big incision, moving everything around, exposing the carotid. Watch your finger. Shot. Shot.
You can't leave it there. Your finger there.
Stop taking your hand off.
Leave it there.
Shot. Just about done. Shot. All right, now stay there. I want to come off. I want to advance this tube. Shot. 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 No, we're not trying to do a biopsy. We want to just get our tube in position. Shot. Watch your fingers. Shot. That's it. Perfect. So we've advanced the tube to the back of the disc where the herniation is, just like we did the last one. And now I'm going to remove the herniation endoscopically. Any questions from our viewers?
Yes, we have a question from Facebook. We have a patient who just had a fusion from C2 to T2, but is still having pain and does not understand why.
Yeah, I'm sorry you're in pain. I could figure out why you're in pain, but I would need to see you. And the best way to do that is to go on to our website. We do free MRI review. Just type in mri.deukspine.com. Maybe you can put the link there and use that link to upload your images, and then I can figure out why you're having pain. If I had to guess, I would say the most likely reason you're having pain is going to be muscles. And that is the most common reason to have pain after that type of surgery. You must have had a posterior cervical laminectomy infusion. Again, there's, unfortunately, as I say all the time, there's a lot of wrong ways to do surgery and very few right ways. I'm not saying everybody needs endoscopic surgery, though I would say you should try to do that if you can. But there is a lot of bad operative technique. And bad operative technique is like bad anything technique. Whether you're a bad gardener or a bad mechanic on a car, okay, your results are not going to be good if your technique is not good. Does that make sense? If you don't water the plants, fertilize the plants, keep the weeds out, give them enough sunlight, not too much, based on the type of plant. And, you know, not all gardeners are created equal. Not all surgeons are equal. So it could be that you have a problem with the way the surgery was done. I wouldn't know that unless I saw your pictures. Specifically x-rays at this point, maybe even a CAT scan, okay? But I can figure out why you're having pain. I just need a little more information other than, here's the procedure I had, why am I having pain, right? So you have a legitimate reason to have pain after surgery. I just don't know what your reason is. Is it a failed fusion? Is it a broken piece of instrument, like a screw that's broken? Or is it that they didn't treat the right area? Is it your muscles? I would like to know what your therapist thinks. Does the therapist think maybe you have a muscle issue? That would be interesting to know. Okay, we're at the back of the disc here at C5-6, and again, there's tremendous amount of scar tissue here, just like the last disc, indicating eons of inflammation. So years of inflammation going on, and inflammation hurts. That's where the pain comes from. That's where the headaches come from. It comes from that inflammatory process going on in the back of the disc. Okay, a lot of arthritis here, and I'm removing the source of the inflammation, which is going to be the herniated disc. Thanks. You got to get rid of the herniated disc if you want to get rid of the inflammation. There's a piece of herniation right there. The key to getting rid of back pain is and neck pain is to get rid of the source of inflammation, which is always going to be the herniation in the back of the disc. All right. Any other questions?
Yes, we have someone in the comment section asking about pain in their tailbone.
Pain in their tailbone?
Yes.
All right. And what is their question about pain in their tailbone?
Has anyone had spinal problems as a herniated disc? Does anybody have pain in their tailbone?
So, pain in the tailbone is the sacrum. It could be the coccyx. The coccyx is a little bone that hangs off the bottom of the sacrum, or what's considered the tailbone. The reasons people get coccyx pain is they usually have trauma to that area, either a fall, and you know it's the coccyx when you have serious tenderness right above your anus. So, like just next to the anus, basically, that's coccyx. And if you push there, not your anus, but just above it, oh man, it hurts like hell. Okay, that's a coccydynia, we call it, and it's fixable. It just takes a shot into the coccygeal ligament. We do that here at Deuk Spine. The other thing that could be tailbone pain is a fracture of the tailbone itself. And the only way to diagnose that is a CAT scan. So I would recommend a CT scan of your sacrum, looking for a fracture. And you can usually ask your doctor to order that. If you're at risk, for example, if you have osteoporosis or osteopenia, you're at higher risk for spine fractures, and especially in the setting of a fall. A fractured sacrum is very common. Again, totally fixable. So I found that most every cause of back pain and neck pain is total. There's a big herniation right there. Look at that thing. They're all fixable. But you have to make the right diagnosis. And Some people have 2 or 3 diagnoses, so they need all 3 things treated. And the other thing you have to do is technically you have to do the treatment properly. You can't just do it improperly and expect good results. So, like I said, in my opinion, one of the biggest problems we have today is that the doctors that we trust to cure our pain, they don't want to cure our pain. These are pain management doctors. They don't want to cure your pain, because they cure your pain, they're putting themselves out of business. So you have to have a doctor who's ethical, who wants what's best for you, the patient. And if you don't find one, you're in deep trouble, because they're just going to use you and squeeze you and use you like an orange tree. You're going to keep coming back and getting more oranges. You'll never get better. You'll just keep getting treated. And I see this happening all the time. They're taking advantage of people and their insurance. And honestly, from an insurance standpoint, that's an example of an unnecessary treatment that doesn't work. So I don't know why the insurance companies continue to cover things like spinal cord stimulators and pain pumps, because they're dangerous, expensive, and they give people a false hope, because they don't really fix anything. All right. Any other questions, Diego?
No other questions, doctor.
I am actually in the foramen right now, zapping away at the herniation. In the foramen on her left. You can see the shape of the foramen. I'm going to come back towards the midline. Things are going well. What is our next surgery, by the way?
Our next one is a right-sided lumbar DLDR at L4-5 and L5-S1.
Thank you. Getting quite a nice variety of surgeries today. Great questions from the audience. For those of you who don't know, Deuk Spine Institute does have an app. Our app is free. You can find it on iPhone and Android. And we have a lot of useful information in our app related to spine care. Feel free to download it. Just about done here. See how much nicer it is when you don't have to take the whole disc out, right? There's no big incision, there's no bleeding, it's just go to the back of the disc where the herniation is and fix it. These are little bone spurs here, by the way, but they're not really bothering anybody, so we don't really mess with them. My surgery doesn't make your disc look normal. Sometimes people don't understand that. We're not trying to make your disc look normal. We're trying to get rid of the pain. And that's really what our goal here is. We're trying to do it without fusion, without invasive, dangerous surgery. All right, just about done here. And then we're going to go to our final disc. Any more questions? This is all scar tissue, by the way. I'm trying to remove as much of it as I can safely.
Yes, we have a question. Where does Dr. Deuk get his instruments from?
I didn't hear what they said.
Where does Dr. Deuk get his instruments from?
Oh, instruments?
Yes.
Well, it depends on which instrument. We get our instruments from a lot of different places. But it depends on which instrument you're talking about. Are you talking about the implants that we put in the last case? That's Alphatech. If you're talking about the endoscopic stuff, it's Richard Wolf in Germany. That's it. I'm fine. I don't know which instruments though they're referring to. I'm not trying to be evasive with you. I don't know which instruments you're talking about. The endoscopic stuff is mostly Richard Wolf. Richard Wolf, it's a German company. They're wonderful. I love their endoscopic stuff. There's other companies out there, but I don't use them. I could, but why change when something works so well, you know? Okay, we're gonna move over to our last disc. As you can see, we've done everything so far with one little cut on the neck. It's 4 millimeters. It's amazing to do that whole surgery with just one little cut. Now I'm going to try to get the last disc. Doctor, if you don't mind giving me that little inline traction with extension. I'm going to move, give me 1 minute. Yeah, go ahead and go lateral. Let me get the fluoro in position. You know, I don't want everyone leaving here thinking that every pain management doctor is bad. They're not all bad. Many of them are good. At least have good intentions. They may not be technically good, but they have good intentions. But I'm just seeing a disturbing number of procedures done by pain management doctors that I believe are completely unnecessary and unhelpful to patients. And I would never do them myself, even though we're perfectly capable of doing them. There's only one reason to do them, and that's to make money. And they don't benefit the patient. So we don't do procedures that don't benefit the patient tremendously. All right, you ready? Doctor, I'm ready. Just, yeah, slight extension. Shot. All right, we're out. Now I need to march along the front of the spine. It's my least favorite part of the surgery, AP. Quick AP. And you know where I am. That looks pretty darn good. Dead center. Let's go lateral again. A little bit of venous oozing. It's normal. All right. I got one more disc to get up to. 2, 3, or 5. Here we go. Shot. Can feel that little edge right there. If I could just, there we go. Shot. Again, I want to make sure I'm in the middle line. Can you give me an AP? Coker? Come on, man. You trying to set Flynn up? Quick shot. Still midline, slight to the right. Almost there. Shot. We're there. I need to check the AP view one more time. Shot. I want to move it a little bit to her, her, right? Her, yeah, I got it. Shot. That looks really good right there. I'm happy with that lateral. Mallet. Everybody stay where they are. We're almost done. That's perfect. Enter the annulus. See it, doctor? Pretty cool, huh? Go mid, you're done. Thank you. And we're going to do a discogram here. Shot. Shot. Beautiful. All right, we'll do our discogram. Shot. All right, good. So we got our dye in. You can actually see the tear. Let's get an AP. Coker. You know what? I don't need a coker. I'm just going to leave it. We're good. So we've done our discogram once again, and I want to see if there's a tear. And there is on both sides. You see the tear on both sides? Go ahead and show them, Jordan. So the tear is in the back of the disc, and you can see the dye going around the nerve root on both sides. It's starting to work its way out in the foramen. That's it. So there's tears on both sides at this disc. All right, come back to a lateral. We're going to debride both tears. That will allow this disc to heal and into a pain-free state. And take a look, folks, at this incision, 4 millimeters. We did 3 discs. Compare that to the last surgery, shot, where we did, the whole neck was open. Okay, we're right on the spine. Mallet, shot. I'm going to advance my dilator a little bit more. Shot. That's perfect. Now I'm going to advance my tube over the dilator. Shot. You always want to keep checking because this dilator sometimes moves. And you don't want it going where it's not supposed to go. Shot. 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 Let me get that dilator in a little bit more. Shot. Shot. Done. All right, now we're in the back of the disc. Removing the dilator. Again, we have access to the back of the disc where the herniation is. And we're going to remove the herniation as well as debride the annular tear using the laser and endoscope. This time we did a discogram. So we have the degenerated nuclear material will be staining blue. It'd be easier to see for everyone, including myself. Okay, I need the scope view. Let's get some lights down. All right, that's good. Okay, we ready? Let's get the laser on. Thank you. Thank you. Piece of herniation there. Any more questions from our audience? That's a herniation right there. What we're doing is creating a pathway for the herniations basically to leave where they are, where they shouldn't be, and to come out and face the music.
We had the patient say that they do have a fracture in their sacrum. How would they be able to treat that?
If you have a sacral fracture, the way it's typically treated is something called sacroplasty. It's basically a kyphoplasty where we inject cement around the fracture to stabilize the fracture. That is typically the best treatment for a sacral fracture. Now, not all sacral fractures can be treated that way, but most of them can be. So you need that X-ray, the CAT scan, not the X-ray, CAT scan, and you really need to make a diagnosis as to where the pain is. If you would like, I could look at it once you get the CAT scan, and I could help you decide what needs to be done. I don't know if you're aware, but we offer free MRI reviews here at Deuk Spine. All that can be done virtually over the internet. So you don't even have to come to my office and see me, and we don't even charge for it. It's free. The reason we do free stuff is we want to help people. And if we do it for free, we're more likely to get people to be involved and, take care of themselves and get better. Our goal here at Deuk Spine is a back and neck pain-free America and world. We don't really want to stop in America, to be honest. We want the whole world to be pain-free. So basically, we go out of our way to help people get answers. We may not be able to operate on everybody, but at least we can give people answers as to what's causing their problem. And why is that valuable? Well, good luck getting those answers from your primary care doctor. They're not going to know. Good luck getting those answers from most other doctors. They don't know. The problem is, there's a herniated fragment right there. The problem is the truth is that 95% of doctors that treat spine problems have no clue why you have your pain. They can't figure it out. They're not capable. They don't have the training, they don't have the expertise, and they don't have the resources available to really do it, like to do blocks, A lot of figuring out pain sources is diagnostic imaging and blocks. And if you don't have a doctor who can do blocks, like joint blocks, then you're not going to be able to make those diagnoses. We do here at Deuk Spine. We have the right doctors here, and we're able to make the diagnosis because we have the diagnostic imaging, we have the block doctors, and we have the treatment doctors who can treat it. So anyway, take a look, get your CAT scan, submit it to our mri.deukspine.com, and I'll be happy to meet with you and do a Zoom call. As a matter of fact, we have Zoom calls coming up this week. I have almost 100 of them to do. And we don't charge anybody for those Zoom calls. I basically spend an entire day and a half just talking to people for free, trying to help them. Spend a lot of money and resources to do that, because we want people to go in the right direction to get better, Somebody helped me out one time when I had no access to good care, and they helped me, and I always appreciate the fact they helped me. So I want to help other people. But obviously there's a limit to what we can do. But at least we can give you a diagnosis and set you in the right direction. Okay, this disc compared to the last one is very different. This disc has a lot of little herniations. The last one didn't. The last one had mostly scar tissue. Oh, look at that herniation coming out of there. Oh, yes. This is so awesome. That came out of the foramen. The left C. What are we doing? 3-4? Are we doing 3-4? Yeah. 3-4 foramen. So that would be pushing on the C4 nerve root on the left side. Okay? Very cool. There's another herniation. And what I'm doing is I'm floating these guys up. Okay? There's another one. And they come out so fast that they're just there. You can see them. You see how quick that is. These things move so quick. I'm doing the annular debridement right there, but that's herniation right there. There's another piece right there. I'm trying to break it up. Oh man. By the way, great questions from our audience today. Appreciate the audience participation.
Yeah, we have another one.
You have another question, no problem.
Yes. We have somebody who has a C3, C4 injury. They say that it's mostly bearable, but one thing that she finds odd is that her thumb curls in.
Thumb curls in.
Yeah.
That's interesting. The thumb should not curl in. That doesn't go along with a C3-4 injury. That's something else. Now, could be tendonitis, it could be a nerve injury somewhere else, but not C3-4. Had nothing to do with C3-4. Sorry. I would go see a orthopedic or I would go see a neurologist maybe. Just about done. Doctor, I need about 10 more minutes. This is yeah, this is definitely a worse one. This is all herniation down here. Make it 15 minutes. A big herniation here. Big. Y'all see that? That thing is a monster. This may be what was causing most of her pain. So she, my nurse is telling me that the patient states her injury was in October, but these herniations are far older than October. But this one could be October, right here.
So she said that she had a fall. She had her back surgery here, lumbar DLDR. She was rehabbing back, working on exercises, slipped and fell, and then felt like a pop in her neck. And she called 911 and she said that it felt like her upper half was on fire. And
Yeah.
she was in the hospital for a week, and then like
Oh, really?
center for 2 weeks.
She went to the hospital for an entire week.
And she didn't see a doctor for 4 days.
She what?
She didn't see a doctor for 4 days while she was there.
Which hospital did she go to? Holmes Regional? The big trauma center here?
And then she
Wow.
said the day before she was
It's horrible.
discharged, she saw a neurology team, and they just had a follow-up outpatient.
So I'm just getting the scoop on this patient. Apparently, she, I fixed her back, I guess, years ago,
So about 6 months ago,
6 months ago, and she was doing a therapy, but she fell, and she was doing great. Her back's awesome, and she went to the hospital. They admitted her, and for 4 days she sat in the hospital without seeing a doctor. That's crazy. Trauma center. Yeah, it's a level. Is it level 1 or level 2? I think it used to be level 2. It may be a level 1. Yeah, a level 1 trauma center is like Shands. That's where I went for training. All these little pieces. Anyway, that's pretty sad to hear. I'm sorry to hear that. Why would they make her just sit in the hospital 4 days?
she said all they did too was just pain meds and stuff. They didn't really do any therapy or anything.
Boy, the quality of care is just deteriorated, huh?
I'm switching your irrigation.
Yeah, I noticed it's getting a little weak. Thanks.
The pumps are so nice.
Good, I'm glad you like them. Luis, are you happy with the pumps? Oh, Luis is happy. Crystal's happy. Oh, I'm happy. Yeah, I think she's going to do great after the surgery. But you can see all this damage here is all relatively new. It is not old like the other discs. So I think it was her C3-4 that was the recent injury. This is definitely more recent than the one we just did, the 5-6. The 5-6 looked old, really old. You see that, doctor? That's the herniation. I've been taking pieces of it out. There's another little piece right there. It's really hard to get out. But you see the end plate, the bone there, right there? That's the back of the vertebral body. So this is all posterior annulus and posterior longitudinal ligament. You see those white fibers there? That's posterior longitudinal ligament. So this is a subligamentous herniation at C3-4. Beyond that ligament is the spinal cord. Hopefully we won't see that. There's a little herniation right there. It went through the ligament. I want to make sure I'm not leaving anything. Oh, there's another herniation. You see all these fragments, though, that are coming out. These are all herniated disc fragments. I'm just giving them a way to get out with this tube, you know? That's literally the dura down there. That's where the herniation ripped through the PLL. Because this is the PLL right here, and that's where it went and pressed on the spinal cord right there. And now it's all gone. I'm just cleaning the last bit up. Watch that wire. Do not let it hit my face. That's pretty much it. We're done. I don't see any more herniation. We're done here. Nice job, everybody. That was awesome. Just love doing these surgeries. I'm not having any suction here. How come I don't have suction? Yeah, now I have it. Yep. All right. So the betadine is an antiseptic. I'd say we lost maybe 5 cc's. No, we're good. So I'm going to show you all this incision. Diego, can you see the incision?
Yes, we can.
Ticky. All right, so the whole surgery, I'm going to take this off, was done through this little tube right here. Can you see this?
Yes.
This is a 4mm tube, and the incision is 4 millimeters. I'm going to take the tube out, and I'm going to apply pressure for a few minutes just to make sure there's no venous bleeding. Pull it, twist it, pull it. Sure. Alrighty. Any more questions? If you have questions, folks, type them up. I'm going to come answer them for you face to face. We're done. That was 3 discs that were repaired. And like I said, the bottom one, C5-6, when I got in there, it was mostly old disc herniation scar tissue. I didn't see really many fresh disc herniation. The first one we did was C4-5. That had kind of a mixture of old and new. And then this last one we did looked like it was the newest herniation. And if you look at the x-rays, she's got the well-preserved disc height at C3-4. So it's a pretty normal disc that she just basically probably injured when she fell. And that's where I found a lot of herniated fragments, at least 15 of them. And we got them all out. There was also a tear in the posterior annulus and the posterior longitudinal ligament. And there was a few herniations sitting right on the spinal cord. You could see the little groove that was there. Okay, here it is. See this incision? Diego?
Yes.
That's a Band-Aid incision. Compare that to the first surgery we did. By the way, our first patient, the 3-level ACDF, already went home about an hour ago, and he was doing fantastic, very happy. We'll see him tomorrow. We'll do a video tomorrow. Hopefully he'll let us, and we'll see how he's doing in terms of his symptoms. Great job, team. You guys did awesome. Jordan, thank you. Thanks, everybody. Crystal, good to have you back. And we've got one more surgery left. For one purpose, and that is to get his neck. I have a very special patient sitting here next to me who's traveled all the way from Tennessee.
Yes, sir.
With his family for one purpose, and that is to get his neck fixed.
In the wild, I've trained animals for 25 years, not jumping through fiery hoops, but just mostly behavior, no, come, just a few words. No, we had 52 big cats, tigers, lions, leopards, cougars, lynx. This is me about 6 years ago in the tiger cage. And this guy here, we raised him from a baby.
That's special.
I'll tell you what, the special part is being here.
And how long have you been dealing with this problem with your neck?
It's come on in the last 8 weeks strong, but after I start thinking about it, even 6 months ago, I was seeing things happen that I couldn't understand why. And I just want to get back to somewhat where I was at and get the feeling back in my hands, my stability, a little strength where I can get this boy up.
Well, what's going on, as we've talked about, is you've got these herniated discs, bone spurs in your neck that are pinching down on your spinal cord and nerves. And I'm going to go in there tomorrow with a laser, and we're going to open all those spaces up, get the pressure off the spinal cord and the nerves, so you can start getting some feeling back and strength back in those arms.
That sounds great. That's why I'm here. Then I've researched, and I kept coming back to you all and seeing the testimonies and seeing, watching hour after hour after hour of the surgery. And that says a lot if you can do it live on Facebook. It's just a pleasure to be here. I feel safe. I feel like when we...
Ladies and gentlemen, Dr. Deuk is on his way. Make sure to write up your questions for Dr. Deuk.
We have arrived. Thank you so much.
We'll see you tomorrow morning, all right?
I appreciate it so much.
So we did surgery yesterday with the laser. Everything went really well. You can actually see the 4mm incision right there, 3 discs. He didn't want fusion, and so he found Deuk Spine Institute and he came here.
After the surgery I talked to you, I was still a little bit drowsy. And 4 hours later, we were sitting over at a restaurant, seafood restaurant, eating seafood, and I could clap my hands at the baby because he claps when he does something good. And I could clap with him without missing my hands.
And you're already getting strength back in your arms and legs. You're getting control of your bowel and bladder back again. That's great news. It's a great sign. I think you're going to keep improving and hopefully get you back to normal.
You are the best. That's why I'm here. That is why I'm here. It is amazing. From the time I walked into this place, I felt at home. I felt like I was with friends all the way through surgery. We walk into this surgical room, everything's so clean. I feel like I'm in a dream. I really do. Thank you so very much for what you've done.
You are welcome. Movement by not fusing, and we don't put anything in your body and leave anything in there. It's all natural. Are you glad you did it?
100% glad I did it.
Yeah.
I tell this story all the time. Everyone goes, oh my goodness, you had back surgery. Are you okay? I can't believe, how are you walking around and you look so comfortable? And I tell them, I don't have anything in me. And I tell them how the surgery went, and I don't mind showing them the video, and they're blown away. And so I often share your website and number with many people.
Thank you. Dr. Deukmedjian here with one of my patients who actually happens to be a musician and is here in the local high school, right? A very large high school for that matter.
Yep, absolutely. The largest in the district.
Largest in the district. And you have how many members in the band?
160.
160 students in the band, and he is the director of that program. Tell me about your back problems before we did your surgery.
I was an active runner and exerciser, and I was out